All right, everyone, welcome to October 2022's continuing education program. So this is another trial that the battalion chiefs have asked me to record the training so that you could watch it at your leisure within your groups at your stations and just get some feedback on this as we go forward. So what are we going to cover as far as our topics for this month? We're going to start out with our infection control, and then we're going to go over some common gynecological emergencies, some OB emergencies, and we're also going to cover the pediatric transport seat, or the ARS. So I'm sorry, the ACR, ambulance child restraint. So we're going to cover those three things. There'll be a little bit of information that you'll have to do on your own. That's going to be in a folder that I will share with everyone. There's also going to be a quiz related to the information that I shared today. You'll also get that within that folder, and there'll be a link. So the quiz will need to be done individually. Whenever you take the quiz, the questions will be shuffled from one person to the next. So it will not be in the same order. Just wanted to kind of throw that out there so you guys would be aware. So we talked a little bit about infection control at the end of our September course. 61-7 is covering a few things that are going to be updated through every service in the state of South Carolina. So figured this would be a good segue to continue our infection control talk and cover just a few things that I feel are pretty important. So hang on. Hopefully you have a cup of coffee and some water and nice comfortable seat. Don't forget to sign in on the roster that's going to be provided and make sure that that is either returned back to me or put in that folder that you removed the sign-in sheet from. Real quick too about the sign-in sheet. So on SharePoint, if you open it up, the sign-in sheet's going to be in the folder that I provide. If you open it and you download that file into, I think it's in Excel, so you download it in the Excel app, save it right away. Station 1 sign-in sheet, Station 2 sign-in sheet, Station 3. As you rename that and you complete all the information by typing it in, you can put it back in that folder. If for some reason you don't do that and you just open up the folder and start typing in, the next time someone else opens it up and they start typing their information in, it's going to overwrite yours. So two ways you can do it, two ways that will be perfectly acceptable to me, is you open it, download it, rename it, put your information in and save it back to that folder, or you open it, you print it out, your guys sign it in, and you scan it in, email PDF to me. So these will be due by October 30th, by the end of the month. So keep that in mind. We're going to start off with, how does EMS prevent the spread? So infection control is one of the main goals in the healthcare field. EMS personnel who don't practice safe and proper infection control allow themselves and others to become susceptible to a variety of infections. It is also important to protect the safety of our patients and to take all steps necessary to ensure EMS personnel protect themselves before treating the patients. So how are we going to do that? Some of the ways that we do this is by proper hand washing. So throughout the last 2-3 years, we have really put a big push to hand washing, hand cleaning, hand sanitizing, watching what you touch, try not to touch your face as often. All of these are things that we can do to help prevent the spread of infections and disease. PPE and protection So PPE is available to every person that works here. We have safety glasses, we have masks, we have gowns, we have face shields, we have all the cleaning materials that you might need to clean your equipment, to clean your hands. And we also have a bloodborne pathogen policy that you can find on SharePoint. So all of these things are put into place to help you reduce the amount of infections and disease transmission between ourselves and our patients. So practice routines, some things that we can do. Good hand washing. So alcohol-based scrubs, normally if they're at least 60% alcohol or higher, they're really good for killing microbes and different bacteria that may be on surfaces on your hands. Antimicrobial is the best type of hand cleaner that you can get. Regular hand soap and water with good friction. Washing your hands, making sure you get your nails on the back of your hand, underneath your ring, if you wear rings, underneath your watch area. Make sure you clean your hands appropriately. You should always do this before and after you come in contact with your patient. I know a lot of times like, oh, I can't wash my hands before I get there to the patient if I'm on the fire truck. Over the last few years, I find myself just whenever I'm near the hand sanitizer, just wiping my hands down. If I'm near a restroom, I'm washing my hands before I touch anything that I'm going to use maybe to eat with or to drink with. You should not have any nail polish of color, long fingernails, things like that. They do they do cause problems whenever it comes to infections and diseases. So we want to make sure that we keep our nails trimmed, no color, and no artificial nails. What are some things that we use, or when should we disinfect our equipment? So what should we disinfect? You see a big picture here. We don't have an ambulance yet. So think about your fire engine, your fire apparatus, your medical equipment that you have on the fire truck, your spine board. And I meant to change that word gurney to stretcher, straps, all the surfaces that you may have touched or your equipment may have touched during the patient care activities, and definitely your Life Pack 15. All these must be disinfected immediately to prevent the spread of infection. So you definitely want to clean it after patient contact and prior to your next patient before placing any of this equipment on the patient. Complete all these tasks on a daily basis. So the more we get into the habit of doing things, the more easily it will come. You'll get it taken care of. Everything will be ready and prepped for your next patient. Don't always allow or think that the person before you's already done this. They may not have. They may have thought about doing it. May have gotten distracted. So especially when you come in, just make sure all of your equipment is clean and ready for patient contact. Personal protective equipment. What is PPE? Proper personal protection equipment must be worn at all times to prevent the spread of disease and infections. What do we have available? Just a recap. We have our gloves, masks, gowns, safety glasses, eye shields, goggles. Personal protective equipment must be put on before the initial contact of assessing our patients. A quick don and doffing video. Of course, this guy has a few more things that we don't routinely use, but it's a really good video. So make sure you take the time, click the next button, and watch this video. right, so that was pretty detailed for donning and doffing. So placing your equipment, putting them on and taking them off. Remember, there are multiple different respiratory type diseases out there right now that we need to worry about. So you got the COVID, got the Middle Eastern Respiratory Syndrome, the MERS, the SARS, and tuberculosis, of course, TB is still out there. So if you have a patient with an unknown respiratory type infection, we definitely want to make sure we're wearing our PPE. The N95 is best for us, and the surgical mask is good for the patient. So the surgical mask being placed on the patient reduces the amount of droplets that are going to escape whenever they cough or sneeze or just talk. So keep that in mind. Some strategies and protocols to prevent infections and diseases. Of course, our immunization schedule. All healthcare professionals are required to have up-to-date immunizations. EMS personnel must have a complete record of your immunizations. So pretty much all of these we can get right at our clinic. So our tetanus, our pertussis, our whooping cough, all the hepatitis vaccinations. Right now, the big one that we need to make sure that we have is our hepatitis B vaccinations. There's a lot of evidence, a lot of strong suggestions that healthcare providers probably need to start getting the hepatitis A vaccination. But that one is one that's kind of up for discussion. It's not really a mandatory one, but I feel in the near future it may be. Influenza vaccinations, we need to start looking at these around our September mark, September through normally February, March is good high flu season. Of course, our COVID vaccinations and measles or MMR, measles, mumps, and rubella. We normally get that one early in childhood. Your Tdap, your tetanus, diphtheria, and pertussis normally comes in one shot. For that one, normally get a booster, let's say every 5 years. So I just got mine a few months ago. Keeping up to date with your immunizations will help eliminate the transmission and spread of infectious diseases. So just keep that in mind. Make sure whenever the clinic staff ask if you are ready for your updated vaccinations, that you and them review it together, and if it's something that you really need, that you'll go ahead and get that done. EMS personnel must follow protocols for treating and interacting with patients by using special protective strategies. So proximity. So like I was saying, our patients that are coughing and hacking and sneezing, they release a lot of droplets whenever they talk. So those type patients, you want to kind of decrease the closeness that you have with them. So a good thing to do is at least at one good arm's length, maybe two, away from the patient as you interact with them. And remember, if you strongly suggest or feel it's a respiratory type disease, make sure you get them a surgical mask and you wear your N95. In conclusion, emergency medicine is dangerous. We run the risk of coming in contact with infectious type diseases. But remember, with good PPE, good cleaning strategies, good immunizations, we can reduce those risks a lot. So make sure we're taking care of that. It's vital that all of these measures are taken into consideration so there's a reduction in the transmissions between us and the patient and between the patients and us. So that's pretty much it about our infection control right now. Vaccinations, super important. The clinic staff is doing a really good job of reminding us when our immunizations are up or when they're due. So please make sure that you follow their directions, follow their guidance, and make sure those vaccinations are done. All right, so that's our infection control. So we're about 30 minutes in. So with that, we're going to initiate our OB and GYN information. So hang on while I get this set up. All right, fine. Got it set up. We're good to go. We're going to go with this one for about 30 minutes, and I'll give you a 10-minute break, and then we'll get started back. So we're going to talk about some common gynecological emergencies, some obstetrical emergencies, just mostly as a review for everyone. I found that this was a presentation that really is needed due to the fact that we don't really deliver a lot of babies in the field. We probably do see a lot of gynecological type emergencies, but sometimes we just see them as just a normal emergency that happens to involve a female that has abdominal pain. But most times it's probably a GYN emergency. So common complaints when it's related to a gynecological emergency: abdominal or pelvic pain, vaginal bleeding, or discharge. And my apologies, but my slides are out of order. So hang on 1 second, or as a matter of fact, go ahead and take your 10-minute break. Come back, and this will be ready to be presented. All right. So if you're back from your breaks in about 10 minutes, we're going to get started again on gynecological and obstetrical emergencies. My apologies. They weren't too far off, but a little bit out of order. So most common complaints is going to be abdominal or pelvic pain, vaginal bleeding, or some type of discharge. So a lot of times our patients are a little embarrassed to let you know that there's some type of a discharge, but they will have the pelvic pain or abdominal pain complaint. Maybe you won't hear about that discharge until you're alone with the patient or at the ERs you're giving report, and then they mention that to the nurse or the physician that comes in. So just a quick cover of some anatomy for our female patients. This is something that's going to come in a little bit more whenever we talk about some OB type emergencies, but you still need to know about some of the anatomy. So we'll start with the labia area, goes into the vaginal area, into the cervix, which is here. And the cervix is normally mostly closed whenever the patient is not expecting or at a stage of delivery. So this opening here, whenever it starts to dilate and efface or thin, is called the cervical os, OS. There's an internal opening or internal os here. I have your uterus area. This is normally where your ovum will implant on the uterus and the process of growing our neonate starts. So we have our ovaries. They protect and store all of the eggs or the ovum. We have our fimbriae on the end of our fallopian tubes. They help guide the egg or the ovum up through the fallopian tube and into the uterus. So once it's in the uterus, it's implanted. And if it's fertilized, the neonate, the fetus, the baby will start to grow. They do flip from left to right as the ovulation process starts. Maybe this month the left ovary will produce an ovum. Next month the right ovary will. So just some review of the female anatomy. So some common complaints that you might find with our patients are sexually transmitted infections, pelvic inflammatory disease or PID. So sometimes this is called the pelvic shuffle. So as the patient is walking, it's very painful. So they have a shuffle instead of a normal stride. So with those problems, sometimes the fallopian tubes, the uterus, and the ovaries are inflamed or swollen. Some other things that you might see is are a type of sexually transmitted disease in high prevalence is gonorrhea, also called CLAP. It's a bacterial infection, which the only good thing about that is bacterial infections can be cured and eradicated or eliminated with antibiotics. It usually starts in the cervix. So chlamydia is another bacterial infection that's a sexually transmitted disease, primarily of the gastrourinary tract. So chlamydia can usually be effectively treated with antibiotics. More than about 95% of people will be cured as they take their antibiotics correctly. Doxycycline and azithromycin are drugs that can be used for both of these. And most times, like I just mentioned, most of them are cured as long as they take the medications effectively and as directed. Some other type of gynecological emergencies that you might see is trauma. One of the things, a term that I've heard recently, probably I may have heard it before, but it's kind of stuck this time. trauma that results in vaginal bleeding sometimes are saddle type injuries. So if your female patient were to straddle something and fall on the labia, vaginal area, sometimes it can result in vaginal bleeding. So if the bleeding is just from the labia, some direct pressure normally can help control that. But they're also called saddle type injuries. Sexual assault. So this is something, of course, we want to be super sensitive about. If we have a patient that has a complaint of a sexual type assault, we want to be encouraging of her to go to the hospital for evaluation. If there's a female provider available, try to have that person interact mostly with your female patient that may have been sexually assaulted. If it's a male patient, of course, you know, a male would be a little better. Just someone there of the same sex for the patient. Try to discourage them from taking a shower, from brushing their teeth, from changing clothes. All of that stuff could potentially be evidence, and you need to encourage them again to go to the ER and see an ER specialist. So for sexual assault, most all ERs have at least one or more nursing staff that is trained as a SANE nurse, a sexual assault nurse examiner. So they will take care of those type patients. Remember again, pelvic inflammatory disease or PID is another source for vaginal bleeding. Coagulation disorders, just someone who does not clot normally, and pregnancy. And we're going to talk a little more about the pregnancy related bleeding in a few slides. So what are we going to do for these patients as we encounter them and they need some assistance with vaginal bleeding? So supportive care mostly is, be empathetic to the patient, sympathetic, take care of the patient, follow your CABDE if needed. If there's not a severe circulatory or bleeding issue, start with your A, your airway, breathing, circulation, any disabilities, and expose and examine the patient. O2 is appropriate, so that's our new catch term. So if your O2 SAPs are less than 94%, they should require some mode of oxygenation. If it's greater than 94%, normally they will not need any additional oxygenation. The only time that really changes is if you have a patient that is expecting, an expecting mom with a traumatic injury. The baby is also living off of her O2 supply. So traumatic injuries, bleeding issues, a hypotensive mom, possibly a mom that's in shock and expecting, those patients require O2 delivery. If there's a patient that's not related to this talk, but you have a patient that is suspected of a carbon monoxide or a hydrogen cyanide emergency, those patients will require additional oxygenation. Always try to transport these patients for further evaluation. If you need advanced life support, if you're a BLS unit or a BLS provider, always try to meet them somewhere on the way, call them early. And again, you've heard this 1,000 times, but we never place anything inside the vagina in order to stop bleeding. So keep that in mind. So that pretty much covers our gynecological type emergencies that we're going to take care of. So with this, we're going to hit our OB emergencies. Hang on one second. All right, so some terminology for our OB section. So para and gravida. Para, the number of times that you were a parent, or that mom has actually delivered a baby. Gravida, the number of times that the expecting mom's been pregnant. Gestation, so this is also known as time of confinement. So the length of time from conception to birth, described in weeks, divided into 3 trimesters, normally, and 36 to 41 weeks. That age range, of course, according to which book you read, normally a normal gestation is 40 weeks. Anything that is less than 36 weeks is considered premature. Anything over 40 weeks is a, trying to think of the term for it, post-gestational time, but it's too much. So labor is another term, the process of expelling the fetus from the uterus, and there are 3 stages of labor, which is also in another slide. So hang on. Our normal OB assessment. So all women of childbearing years should be considered pregnant. Again, childbearing years, I've heard at least from 10 years old to 60 years old. Some documentation that you might read may say 12 to 50. So just follow your normal protocol, and any woman who has any abdominal pain and she's premenopausal, you should consider that they may possibly be pregnant. How are you going to find out? A good history. Ask them some questions, and hopefully that will shed some light on what you're dealing with. So their due date, or the date of confinement, or current gestational age, are some things that you need to know. Do they have any current or past OB complications? Onset of symptoms? When did all this start? Assessment of blood loss, or how many sanitary pads have you used that have been saturated with blood? If they're available, take them with you. Let the nursing staff know or see those. So current or past OB issues. So is the patient currently expecting? Does she have hyperglycemia or gestational diabetes related to the pregnancy? Is she preeclamptic? Basically meaning, does she have high blood pressure related to the pregnancy? Past OB complications. Did she deliver early? Did she have issues during delivery? A lot of questions that you can ask to try and get some good information about what you're dealing with. OB emergencies. Placenta previa. So this is one that we're definitely going to hit in just a few minutes. Abruptia of placenta, spontaneous abortion, uterine rupture, preeclampsia, eclampsia, and ectopic pregnancies. But before we get into those OB emergencies in general, we're going to talk a little bit about the hormones that are readily available and moving within our expecting mom prior to those emergencies happening. So again, we have our anatomical model there, the type of hormones that are going to be produced in each area, in our female reproductive area and in the brain. So our ovaries and glands that produce the female sex hormones produce the reproductive cell, or the ovum, or the egg. Our fallopian tubes, or ducts, are the tube that transports the ovum to the uterus. Conception commonly occurs in the fallopian tubes, which is not a good thing. And we're going to talk about those ectopic pregnancies in just a couple minutes. Luteinizing hormone, follicle stimulating hormone, estrogen, and progesterone play a huge part with these hormones that we're going to talk about. And we'll get a little more detail with them. So right now, just estrogen's important role in sexual and reproductive health and development. Progesterone basically facilitates the implantation of the egg. Luteinizing hormone just basically helps the ovaries and with ovulation and actually moving that ovum and preparing it for movement into the uterus. The follicle stimulating hormone stimulates the follicular production. And again, those two work really close together. So with this, the follicle stimulating hormone and the luteinizing hormone are secreted and initiates the menstrual cycle. So the menstrual cycle is basically a cycle that changes and it occurs throughout childbearing years. Each cycle is about 28 days. The follicle stimulating hormone stimulates the follicle. So if you think about FSH or follicle stimulating hormone, it's basically thinking about the follicle that's in the ovaries that's going to change into or turn into or mature into the ovum that in turn produces the hormone estrogen. So as the follicle stimulating hormone and the luteinizing hormone together, they bring about ovulation or releasing that ovum from the follicle. And then as it does, it passes through the fimbriae, or the fimbriae help move it into the fallopian tubes. And as it's inside the fallopian tubes, it moves, hopefully, all the way through until it gets to the uterus and implants on the uterine wall. So as it implants on the uterine wall, the endometrium, or that area that's implanted on, will start to thicken, start to cover that ovum. And as it does, there's a time period there with a lot of scientists, a lot of specialists in this area. They really don't know exactly what happens, but from that point, the baby's attached, the placenta starts to develop, the umbilical cord starts to develop, the amniotic sac starts to develop, the fluid within the sac. So all of that is starting to happen in this area because of these hormones. There are other effects of estrogen on a woman's body. And again, men and women have estrogen, progesterone, and testosterone. We're just going to talk about estrogen and progesterone right now. As you see on the screen, estrogen affects the brain, helps with body temperature adjustment, memory, and libido. It affects the liver with cholesterol production, bones with strength and density, the skin, just as you have enough estrogen through your body, you don't seem to age as much, but once that estrogen level starts to fall, that's when you start showing your age. Helps protect the heart. It's helps with the breast growth and feeding function. As far as the lactation, there's other hormones that help with that also, like lactin. Helps mature the ovaries and getting them ready to release the ovum. And the estrogen is a monthly preparation, or helps with monthly preparation for pregnancy or the menstrual cycle. So if the ovum is not fertilized, then the estrogen level drops, progesterone rises, and it causes the menstrual cycle. What does progesterone do? Although the main progesterone roles concern menstruation and pregnancy, the hormone has several other functions, such as it assists in regulating blood pressure, supports cognition or thinking, protects your bones, and helps lower cancer risk. So progesterone has a lot of other things that it does other than assisting with pregnancy. So one of our first emergencies or bleeding issues that we might have or encounter is placenta previa. Placenta is implanted low in the uterus. And of course, every book, article, or whatever you may read may have different types of things that you'll see. It's really good for education because everything is not always black and white and exactly the way your book reads. Other people have found things that are different. So placenta previa, the way that I've always understood it is the placenta develops either over the cervix or very close to the cervix. So as the baby starts to grow, the fetus starts to grow and get larger, it starts to stretch that placenta. And as the baby gets larger and larger, and the placenta had implanted itself over the cervical os or the cervix, as it starts to grow, it could tear that placenta. And when it does, you're going to notice bright red bleeding coming from the vaginal area. And most times it's going to be painless. The placenta is currently not innervated. It's torn. It's really close to the outside world coming through the vaginal opening. And the blood's going to be bright red and normally painless. Some other things you may see. So signs are things that we see, symptoms are things that the patient tells us. So you may have a soft, non-tender uterus. Bleeding may be episodic, will increase with the onset of labor. So could you imagine the contractions causing that to stretch and to get larger at the cervical opening, and that bleeding could continue to get worse, especially if it was late or it started to happen later in the pregnancy. So placenta previa normally have signs and symptoms in the second or third trimester. What are we going to do for it? Rapid transport. Provide oxygen, treat for shock as needed with the patient, transport to an appropriate OB-capable hospital. So pretty much any ER should be capable of delivering a baby that is being delivered by normal means. But whenever you have something that's a specialty issue, if there's a OB-capable hospital or a hospital that's capable of more than just standard delivery, try to transport the patient to that hospital. Placenta eruption. So with this one, normally the placenta is in the appropriate place. It's implanted high in the uterus, not over the cervical os or not over the cervix. So it's in the right spot. But for some reason, the placenta abrupts or tears away from the uterus. So whenever that happens, a lot of times the blood is captured between the uterine wall and the placenta. So whenever that is there, the blood is there, it can cause significant pain to mom, abdominal pain. She could have a rigid abdomen. And if it opens up so much that blood bypasses the baby and actually comes out of the cervix, normally that blood is going to be darker in color. And the other thing that you're going to see with your patient is a severe, painful abdomen and possibly a rigid abdomen. Usually becomes apparent in the third trimester. Again, this one in most books, second and third trimesters, painful, tender, rigid abdomen, sudden dark red vaginal bleeding, may be out of proportion with the degree of shock due to internal bleeding. We're going to rapid transport this patient, provide the patient with oxygen, treat for shock, and transport to an appropriate OB-capable hospital. And just throw in here, because I don't think I have it in the slides anywhere else, but if this patient is in shock and we're providing fluid to the patient, we want to make sure we use the 20 mLs per kg for this patient and use lactated ringers. All right. LR just replaces some of the common elements that our body has naturally, and it's the best fluid for the situation. One of our other emergencies we might encounter is spontaneous abortion, also called a miscarriage. So this is not a scheduled abortion. This is just something where the body, for whatever reason, rejects the fetus and it is expulsed from the uterus before week 20. So before week 20. So I'll tell you, there's something else that happens around week 20, and that is that you can actually feel the fundus or the top part of the uterus right above the umbilical area on your patient. So if they're 20 weeks, you can feel that fundus. Normally, they don't know how far along they are. That's a good rule of thumb that you could use. So some of the things you're going to look for, most time this occurs within the first 13 weeks of pregnancy or during the first trimester. They may have very little or profuse, a lot of vaginal bleeding. And you may see tissue or what appears to be tissue. If you notice that and you're able to capture that, please try to bring that to the hospital with the patient. It could actually be the fetus according to how many weeks along she is. And they can do testing on that tissue or that fetus to see possibly what the cause of the abortion was. If they can find out what it was, maybe the next pregnancy, they can help the mother with those issues. So they may have cramping or supra right above the pubic area pain, sometimes referred to the back. They may be very anxious and they may be hypotensive and they could be showing signs of shock. So as we saw with the other couple patients, there's things that we can do for those also. Rapid transport, O2, treat for shock as needed, transport to a capable, appropriate hospital, and bring any of the tissues or products of conception with you. Another common, not so common emergency is uterine rupture. So uterine rupture most times is a problem with trauma or traumatic type injuries, either abuse. It could be from a fall, a car accident, where the baby actually, or the uterus actually ruptures and the baby is outside of the uterus. All right, so outside of the uterus, somewhere in the abdominal cavity. Not good for mom. It's not good for the baby. This can happen sometimes if they're post-gestational after the 40 weeks, if they are have gestational diabetes and the baby's really large. It could happen just based on mom. She had a cesarean section before and she has weak abdominal muscles. The uterus's muscle is not very weak. I'm sorry, not very strong. And then the baby ruptures through the uterus into the abdominal cavity. So if you hear terminology like VBAC, so vaginal birth after cesarean, most times once you have a cesarean, the OB physician will not want you to have a vaginal birth just due to the weakening nature of your muscles. But some women choose to do it with the approval of their physician. Some don't have any choice because they're either away from the hospital, away from their physician, and delivery is imminent. So if uterine rupture occurs, some things that you may see or the patient may tell you, it can occur during active labor. Could be a tearing pain, which is sudden. They may show signs of shock, nausea, vomiting, thirst. Usually bleeding may be internal. So internal bleeding, bleeding that you can't see. Abdomen may be tender and rigid. What are we going to do? Rapid transport. Take them to an OB appropriate hospital, treat them for shock, monitor their airway, breathing, circulation, get vitals, and get more than one set because we want a trend. We want to see how well they're doing, if they're reacting well to our treatment or if they're getting worse. Preeclampsia, also called toxemia, are pregnancy-induced hypertension. So these are basically our vessels are spasming, our cell injury and blood clotting issues. So women in their 20s are mostly affected, their first pregnancies. They have pre-existing problems like hypertension, heart disease, or diabetes. And if they don't get treatment for their preeclampsia, they could become eclamptic. And basically that means that their blood pressure has elevated to the point to where it stretches the meninges of the brain, causes problems with the electrical activity of the brain, and seizure activity starts. So we'll talk about some more of the treatment for eclampsia as we get into the next set of slides. Things that you might see with preeclampsia: a lot of weight gain, sudden weight gain, a lot of swelling to the face, hands, and their feet. It's almost like the HELP syndrome. Hypertension, diastolic above 90, decreased urine output, headaches, blurred vision. So a lot of the things that you're going to see with a hypertensive patient. Like I said, the preeclamptic patient becomes eclamptic. Maternal death rate is up to 15%. Fetal death rates 25%. Most of these are going to be related to a hypoxia type issue or problem. So we need to make sure that we oxygenate these patients. We transport them to a capable hospital, anticipate seizures, have suction ready, and with the, sorry, it's not in here. I thought I put it in here, but with the ALS treatment of this patient, they need initially some mag sulfate. It's a smooth muscle relaxer. So what that's going to do is it's going to relax the muscles, help lower that blood pressure. And if that does not work, your secondary, your follow-up is going to be some type of a benzodiazepine, right? The normal treatment for seizure activity. So our next things are ectopic pregnancies. So ectopic just means outside of the normal area, ectopic. So as you notice, you can see my cursor here. You have your ovary, your fimbriae. So normally your follicle is stimulated, it grows into the ovum, it starts to move. And if you notice right here, that's as far as that one got. So if it would have made its way to the uterus, same thing would have happened. It would have been encapsulated. It would have started the process of creating the placenta, the umbilical cord, the amniotic sac, and everything. But it did not make it here. So it's starting to do that process right in the fallopian tube. Okay, that is a problem. Whenever that happens, it cannot grow very much before it rips, tears, and starts to bleed. So within the first 12 weeks, this is definitely going to be a huge issue. Any female patient of childbirth or childbearing age that presents with acute abdominal pain, that should be on your list of differentials that she may have an ectopic pregnancy. All right. This is just basically showing you all the places that the ovum could implant this ectopic. Sometimes it does not even make it into the fallopian tube. It's delivered outside of the ovary, and it drops down into the abdominal cavity somewhere. And if it does, same thing. It's going to try to implant. It's going to try to grow, and that is not the place that it should grow. What are some things that you're going to see? Signs and symptoms usually becomes apparent early in the first trimester, the first 12 weeks, often even before the patient's confirmed to be pregnant. Sudden sharp abdominal pain, localized to one side, spotty vaginal bleeding, and whenever you ask about the menstrual cycle, they have missed their last menstrual cycle. Treatment, basically the same as any other but I would add like a check mark in front of that rapid, and they need to get to the hospital really quick. Supine hypotensive syndrome. So with these patients, basically their gravid abdomen, their abdomen's getting larger due to the growth of the baby, that 50% extra blood volume that they have, the extra fluid that they're carrying, the extra weight that they put on. So that abdomen is going to be compressing their vena cava and causing a decrease in blood return to the heart. So whenever that happens, the patient can have a syncopal episode or become severely hypotensive when laying supine. So if the patient has a syncopal episode, she has a near syncopal episode, and she's hypotensive, always try to lay her on her left side. Over to her left side, make her comfortable, see if that helps with the issue. So with that, that is all the initial emergencies. We're going to go into a little bit of delivery information now. So we're going to do a fire department simulated delivery and cover a little bit of information. So this is a new delivery doll that they have over at York Technical College. And I call her Noelle. I'm not sure what her name really is, but she delivered 16 babies in one night. And these guys were part of that. So she actually delivers the baby. This baby will actually cry. He'll be cyanotic. We don't cut the cord, but we do show the students where to place the umbilical clamps and where to cut. So how to suction. I mean, it's a very, very good tool. So hopefully one day we can get a little program going so that some of our guys can go over there and train. So our childbirth protocol is actually updated as of 2021, and these are the things that you should do whenever you deliver a baby. So we're going to support the baby's head, remove the amniotic sac from the face during delivery as needed. So if you ever see PRN in our protocol, these are things that can be done if it's needed. Suction the mouth first and then the nose with the bulb syringe. And there should be a PRN right there by that. We don't have to suction a baby if they're born and they're active, they have a good cry, there's no meconium. So just keep that in mind. Deliver the shoulders and continue supporting the baby's head and body. Make sure you got a good grip on the baby. They are slippery at birth. Keep the baby on the same level of mother's vagina until the cord stops pulsating. So delayed cord clamping is something that's out there. There's a lot of evidence to support it. So what I like to teach is during that first minute, you deliver the baby, you assess the baby. Does the baby need suctioning? You dry, warm, you stimulate the baby. You wrap the baby up you discard the towel that you use to dry the baby off, to wipe the baby off. You discard that one and you get your second one. You wrap the baby up. You put him in a warming blanket or a Mylar wrap. So you have him in that. All of that, So all of that takes at least about a minute. So while you're doing that, you're going to take your clamp and you're going to place it 6 to 8 inches from the baby, the first one. The next clamp is going to go about 2 to 3 inches from the first clamp. Boom. It's already, the umbilical cord is already stopped pulsating. So at that point, you can cut the cord. If dad's there and he's got a level head and a good mind about himself and he wants to cut the cord and it's okay with mom, you're more than welcome, but give him some good directions. Cut between the clamps, all right, in the middle, between them. All right, note the delivery and the APGAR score. So we need to know the appearance, the pulses, grimace, activity, and respirations at 1 minute and at 5 minutes. All right, 2 things we need to do. Post-delivery, Allow the mother to nurse as needed prior to transport. And the reason prior to transport is there is because we should not allow the baby to ride on mama's chest on the way to the hospital. We don't want to have a problem and get in an accident on the way to the hospital and the baby becomes a projectile or an airbag for mom. All right. If the placenta delivers prior to transfer of care, save all the placenta and afterbirth tissue. So in your OB kit, there's a clear bag with some bread ties. So put the placenta and the other part of the umbilical cord inside the bag and close it up with the bread ties. So we don't want to put that placenta in the red bag and it get placed in a biohazard trash can. All right. It needs to be placed in that clear bag and given to the physician at the hospital. Postpartum hemorrhage. Place a sterile dressing over the vaginal opening. Do not pack the vagina. So basically, there is normally some very minor bleeding following delivery. So with that, you're going to open up that that pad. There's a sticky side. You peel the sticky side off, and you place that right on the outside of mom's vaginal area. And you can place her legs together. You don't have to hold them together. Just ask her to try to put them together, put her on her left side, or make her comfortable and transport her to the hospital. If there's a lot of, or if there's more bleeding, massage the fundus in a circular motion right above the suprapubic area. So you're just going to massage that area. Encourage the mother to nurse. That will help promote uterine contractions and help stop that bleeding. If the perineum is torn, control bleeding with direct pressure. So with that, direct pressure is actually on the outside. That's between the vaginal opening and the anus. That's the perineum. So that's where you can actually place a pad. Complications, if there's a miscarriage, transport the fetus or the tissue with the patient to the receiving facility. If the baby is breached, and we got a couple slides on that too, meaning there's something other than the head that's presenting, that's a problem. We need to urgently transport the patient to the hospital. We'll talk about that a little bit more. One big thing about this area, do not ever pull on the baby. Don't pull on the baby's head. Don't pull on the baby's legs if they're the presenting part, their arm. We're not going to try to, we should not ever try to pull a baby out of the vaginal canal. Umbilical cord, we're also going to talk about those in a slide that's after these. Umbilical cord complications, if the cord's wrapped around the neck, which is also called a nuchal cord. We're going to try to gently slip that cord right over the back of the baby's head. If we can't, and there's enough cord that's outside of the vaginal opening, we can cut the cord. Make sure we clamp it first. Clamp it, 2 spots, and you can cut it. Prolapse cord, that's one of the only times you'll actually place your hand inside the vaginal opening to keep the baby's weight and any tissue off of the cord so that it can still supply the fetus or the baby with oxygen and nutrients. All right, this is our childbirth protocol. It is in our medical best practices, so make sure you take an opportunity to look at that. The stages of labor, again, so stage 1 begins with the onset of labor, and it goes all the way until the cervix is dilated and effaced or thinned. Dilation should get up to about 10 centimeters, and that should be fully dilated and effaced, really thin. Stage 2 begins when the fetus enters the birth canal, ends with the delivery of the baby out of the birth canal. So stage 1, everything's ready. Stage 2, the baby is delivered. Stage 3 is when the placenta delivers. All right, so our assessment. Is the mother multigravida? So has she been pregnant more than one time? When do the contractions start? How frequently are they? How long do they last? Has the amniotic sac ruptured or the mucus plug been expelled? Does the patient feel the need to move her bowels? Is crowning present? Is delivery imminent? So all of these things are some questions that you need to ask. So multigravida may also mean, is she having more than one baby? Does she have twins at the same, she have twins at this time? How long do the contractions last? So if they're 15 minutes apart, you got a little time. If they're 30 seconds, 1 minute apart, you probably need to start making preparations to deliver. The mucus plug. So normally that's also called bloody show. So you may get there and first time pregnancy and they're a little anxious and they show you what it is. Don't be surprised if it's just a little small mucus, bloody looking clot, basically. All right, could be the mucus plug. Amniotic sac, normally it's just some clear fluid. If the amniotic fluid is foul smelling and the baby is imminent delivery, get your resuscitation equipment ready. All right. So needing to move her bowels. This is one time we really want to be kind of stern and do not allow the patient to go to the bathroom. If we allow the patient to go to the bathroom because she thinks she needs to go and have a bowel movement, and it's actually the baby putting pressure on the rectum area, and she delivers the baby into the toilet. Now we have big problems, right? We don't want that to happen. Crowning and imminent delivery, there's going to be a time where she says she feels like she needs to move her bowels. She feels like there's a lot of pressure between her legs. She's been having contractions for 12 hours. And last time she went to the doctor for evaluation, she was 8 centimeters to send her home. You're probably going to deliver that baby at home. So place the patient on a firm surface, semi-Fowlers with their knees up. So this is also called the McRoberts position. Drape over her legs, put her drape under her buttocks. Make sure you have your gloves and gown on if you can. If you have time, make sure you put on some safety glasses or goggles, and your OB kit is readily accessible. Look for crowning, and your job is basically there to just assist. Encourage the patient to push or bear down whenever she has the contractions. Support the baby's head, especially when you first see the crowning. Place your hand right at the vaginal opening over the crowning portion of the head so that it will help the baby not have a really quick delivery, and it will also help decrease the tearing possibly of mom. So if the umbilical cord is wrapped around the baby's neck, also called a nuchal cord, try to slip it over the shoulder or the head. If it's too tight, you can clamp it and cut it. All right. So what this is implying is that you can already see the baby's head. It's out, but the cord's around the head. So normally just reach in, put 2 fingers under the cord at the back of the head and just push it right over the head. If for some reason it's super tight and it will not come off, carefully and gently clamp that cord in 2 places, and you should be able to cut it away from the baby. Don't cut the baby. So this is an example of the baby initially coming down. It should be cephalic in nature. So the face should be toward the posterior portion of mom. So as the baby comes out, if needed, we will suction the mouth first and then the nose. And once that happens, we will gently assist mom. We're not pulling, we just have our hands there to assist. And as those shoulders deliver, place your hand right there on the shoulders. Make sure you got a good grasp on the baby, and the rest of the baby should deliver pretty easily. All right. Leave the baby at the level of the mom's vaginal opening while you do your assessment, while you dry, clean, stimulate, suction if needed, and wrap and start to warm this baby. Should be about a minute. And then we're going to find our cord place or our clamp placement for our cord. And the cords or the clamps are going to be 2 inches apart, but disregard is 3 to 4. So we're going to go 6 to 8 inches away from the baby, cut between the clamps. The placenta will deliver itself in about 10 minutes or so. Dry the baby and immediately wrap in a blanket or towel, place on its side on the mother's chest. Clean the baby's face, suction if needed, and record the time in the APGAR score. So APGAR score 1 minute and at 5 minutes. Just a quick little pictorial reminder of where to cut the cord. Please, please, please remember, cut between the clamps. All right, between. Meconium, if you happen to see meconium, basically the baby has defecated inside the amniotic sac, and that is what the meconium is. Yellow, greenish coloration of the amniotic fluid, can have a foul smell. If you happen to notice that, make sure you suction the baby as soon as you can, as soon as that head is delivered. Suction that mouth and that nose, because as soon as they take that first breath, it's going to go down into their lungs. The placenta, again, should deliver within that first 10 minutes. Blood may gush from the vagina once it delivers. Massaging the abdomen over the suprapubic area and letting the baby breastfeed could help with that bleeding. Never pull on the umbilical cord to speed delivery. You can have slight tension on it, but do not pull on it. If bleeding is continuous and severe, transport immediately to the nearest appropriate facility. Control any bleeding externally that you can. Never put anything inside mom for bleeding. Apply oxygen and treat for shock as necessary. So we talked about the APGAR score briefly. So APGAR, appearance, pulse, grimace, activity, and respirations. Highest score you can get, a 10, is a 10. A normal score for an APGAR is going to be 7 or 8 for a baby that's born. Normally your initial 1 minute APGAR normally is about 1 or about 7 to 8. So I like this one here. It is a pictorial of what they should look like. So if they have a good normal color, they get a 0. If they have, if they are cyanotic all over, they get a 0. If they have central cyanosis, the head and their trunk, they get a 1. If they're pink all over, they get a 2. So pulse, they don't have a pulse, they get a 0. If it's less than 100, they get a 1. If it's greater than 100, they get 2. No grimace at all, 0. A slight grimace or a very defined grimace, they get a 2. Activity, no activity, a little activity or excessive activity, they get a 2. Respirations, none, 0. Weak or slow respirations, a 1. A strong cry, they get a 2. All right, so 2, 4, 6, 8, 10 is the highest that you can get. A lot of our babies are going to get that 7 or 8 mark. Okay, just remember our resuscitation issues. If their heart rate is less than 100, we're going to make sure they're dry, warm, stimulated. We suction them, and we're going to ventilate the baby without oxygen initially. Bag mask ventilation. Recheck them in 30 to 60 seconds, see if their heart rate is improved, see if their APGAR score is getting better, especially with their respirations. Their heart rate gets less than 60, we're going to start CPR. With the newborn, our CPR is 3 compressions to 1 ventilation, 3 to 1, right? So abnormal presentations, breech presentation, anything other than the head that's presenting, limb presentation, also breech, and then prolapsed cord. Vertex is normal. It's what we want. We want the baby to be looking to mom's posterior upon delivery. They will turn as the shoulders deliver. Breech presentation, basically the head's delivering last, which is not good. Mom may know, or the expecting mother may know that the baby is breech. Just due to her doctor's visits, they'll know if the baby's turned or not in the right position. Breech presentation should be delivered in a hospital where a C-section is possible. Field delivery is possible, but there's a much higher risk of trauma and the process may be slow. So those patients, we want to support them, transport them quickly to a hospital that can take care of them. So breech, if you do have to deliver in the field, ensure there's no tension on the cord. So if the cord is out, you may need to place your hand in to move tissue or keep the baby's head off of the cord. Morisot's maneuver, basically inserting the fingers from the V-type pattern so that the baby can breathe without that tissue stuck to their face. A lot of times, just by placing your hand under with that V, you're slightly elevating the baby in an anterior fashion, and it help with delivery. Just do not pull on the baby. If they're stuck there, just keep that V pattern and try to keep that tissue away from the baby's mouth and nose. So limb presentation is just what it means. It could be an arm, it could be a leg. Prolapsed cord. It's basically when the cord comes out before the baby. This is an emergency. We want to not encourage mom to continue pushing. We need to place her in the on the stretcher. She's not already on there, and rapid transport to the hospital. You may need to place your hand inside the vaginal opening, just keeping the baby's head away from the cord as much as possible. Try to also keep a check on that cord and make sure it's still pulsating. As long as it's pulsating, it's moving blood to the baby. I briefly hit on the premature infants as being less than 36 weeks, less than 5 pounds. Sometimes mom didn't have any prenatal care, or she does not realize she's pregnant. So she may not know how far along she is. The babies are born and they're smaller or thinner. They got a much larger head than the rest of their body. They haven't been in there long enough really to get this vernix cassois white coating over their body, and they don't normally have as much hair. If they're premature, or if they're delivered at the normal 40-week range or greater than 36 weeks, keep them warm, keep them warm, keep them warm, keep them warm. Make sure their mouth and their nose are clear. Ensure there's no bleeding from the cord. Administer oxygen if needed. If needed, the oxygen. Most babies, they have a preductal oxygen saturation of 80%. And over the next 10 minutes after birth, their O2 saturation slowly increases into the 90s. So we want to retain from giving them oxygen unless we absolutely have to. Protect from infection, use sterile equipment, wear your face mask, monitor APGAR score every 5 minutes or sooner, and always be prepared for resuscitation of the newborn baby. Any questions? All right, so we're at a 10-minute break. So if you guys will, just pause the video, stretch your legs while I prepare the next portion. All right, so I actually had a request for this not very long ago about going over the ambulance shower restraint again. So not only are you going to watch this video, but I do have plans in the near future to try to get everyone together and put this on a stretcher again. Um, Again, I told you guys, it's not a piece of equipment that we have, but whenever there's a pediatric emergency, the providers are a little stressed just because of the low incidence that we have pediatric patients to take care of. Um, if it's a newborn or a baby, you need all hands on deck. So if they ask you to assist with placing the ambulance shower restraint on the stretcher, you need to have some idea of how to do that. All right. So watch this video. It's I don't know, I think it's about 8 or 10 minutes long. Watch it. Um, just refamiliarize yourself with the ambulance shower restraint, and the next time we get together, we'll actually put it on a stretcher. All right, so that is everything. We're going to talk real quick about documentation. So don't forget, you will have your sign-in sheet. It'll be on a link that I'm going to send you. Watch all the videos. There's going to be a quiz attached to the email that I sent out to everyone. And there's also going to be a Jeopardy game. So you can just do the Jeopardy game with your groups. It's going to be very good information as a reminder. If you have any of our new employees that are currently in EMT class, they've seen this before, but it's going to really help them with test questions related to OB, GYN, infection control, whenever they take their national registry test. So thank all of you for your attention. I hope this video is acceptable to everyone. I tried to get it done in one take, so if there's a couple little things that you had to wait on, my apologies. You can always talk with Chief Long about buying me some video editing software and equipment, and I'd be more than happy to provide some edits in there. But thanks again. I will see you all during our next training or around the station.